And one of the things a young person said to me a couple of years ago is like, I don't know the intricacies of how the government works, but I know what doesn't work and I know what I need. And like, you need to help me figure out the policy solutions. And at the risk uh, of being tried, I mean, the place that I find hope is with young people. They are sophisticated and thoughtful and loud and present and in the mental health space, like they're there and they're asking us for the kinds of care that they need.
Hello and welcome to Thrive Dispatches, a podcast from the Thrive Center for Children, Families, and Communities at Georgetown University. I'm Matt Biel and I direct the Thrive Center. I'm a child psychiatrist and I focus on advancing the mental health and well-being of children and families. This season on Thrive Dispatches, we're focusing on extraordinary solutions for extraordinary times. And these are extraordinary times indeed, particularly when it comes to federal policy affecting children's mental health and well-being. Today, I'm speaking with Dr. Sunny Patel, a child psychiatrist and one of the nation's leading voices on children's behavioral health policy. Sunny previously served in the federal government, where he worked on critical issues including school-based mental health care and children's online health and safety. He brings a unique perspective, both as a clinician who sees patients every week and as a policy expert who understands how decisions made in Washington ultimately show up in exam rooms and schools across the country. In our conversation, Sunny and I traced the recent history of children's mental health policy, from the bipartisan momentum that was building just a few years ago to the current moment of uncertainty and rapid changes in federal policies. We talk about what's at stake for children and families, why America has historically underinvested in children, despite strong evidence for doing otherwise, and most importantly, where we go from here. This is a conversation about crisis, yes, but it's also about opportunity for paradigm shifts in how we support children's behavioral health and family well-being. Sunny brings both moral clarity and pragmatic wisdom to these questions, and I think that you'll find this conversation as illuminating as I did. Enjoy. Dr. Sunny Patel, welcome to Thrive Dispatches. Thanks for joining me.
Thanks for having me. It's a pleasure to be here.
I'm glad to have a chance to chat with you. You know, you are you're my go-to in trying to understand things happening in the federal government and how that impacts the health and the well-being and the everyday lives of kids and families in this country. And this period of time, I've had more questions for you than ever.
Yeah.
And so I'd love to start with just you helping me to understand through your expert lens and through your experience, what's going on right now with the federal government and with funding and regulation and policy that you think is really going to affect kids and families.
I mean, I think to sort of talk about this moment, we probably just need to rewind a little bit to figure out how did we get to this exact moment, right? And I think looking back at the last 5 years, and the sort of prior to the pandemic and to the moment we're finding ourselves in, children's mental health was maybe the one real bipartisan issue that we could find a common ground on, right? National associations, including the ones that you're a part of, sort of rallied a cry around a youth mental health crisis. The Surgeon General made it one of his top issue areas, right? Federal resources were garnered towards supporting youth mental health, including through the Bipartisan Safer Communities Act that was passed in 2002. There was tons of...
In 22, right?
22, yeah. And there was tons of resources that were brought to bear in funding and sort of commitment to tackle this issue head on, right? In a way that I don't think either of us in our careers as child psychiatrists have seen before, right? We're sort of the cool kids at the party. maybe for the first time. And and that kind of changed in tone within the last year. And I think th there's sort of a bit of a pendulum swing of, wait a second, like what, why is the rate of diagnosis of autism going up? We need to figure this out. But I think one of the challenges is uh, there's been sort of, instead of asking questions in the form of a hypothesis, which is how we would approach it in science and medicine, uh, it's sort of reverse of, we know the causes and now we need to tackle them, right? Like whether it's vaccines or SSRIs and its links to school shootings or other sort of false claims, it's sort of we find ourselves in a challenging moment as it relates to children's mental health because uh, if that's sort of the philosophical belief at the federal level, well, then that it follows, how the resources would sort of be distributed, right? So I think the second part is a financial sort of issue, right? Around sort of how dollars are distributed and allocated. And generally, Congress controls the power of the purse. There's authorization that, Congress passes, and there's appropriation, so dollars that follow the authorization. And we sort of follow, like that's the blueprint in how the federal government sort of executes its domestic policy agenda. That does not seem to be happening right now, where the government unilaterally is saying, we're going to cancel these grants, we're going to cancel these contracts. But often these are issued in accordance with the law. And so um, uh, it leads to lots of uncertainty. And I think the downstream effects are we're finding ourselves in a moment that it's leading to uh, angst and uncertainty for providers who are delivering services and to communities that desperately rely on them. And so that's sort of the narrative arc of how I think sort of contextualizing the moment we're in.
So Sunny is helping us understand how we got to this moment. A shift from unprecedented bipartisan support for children's mental health to what he describes as an approach that's narrative first and will worry about the facts later. And as he explains, this isn't just abstract policy debate. When leaders plant seeds of doubt about well-established treatments and interventions, those doubts show up in real time in pediatricians' offices and mental health clinics across the country. Let's hear more about what this looks like in practice.
And yet, these are the medicines that have been almost the most studied medicines in child psychiatry, right? Like it's not like it's a new kid on the block. And I sort of think we're in an era of no new news, and yet there's new policy, right? And so I think about it, like if there was a groundbreaking study that said one shouldn't do whatever practice, right? Like that would make sense, right? Like, I think there's been focus in the administration on antidepressants in pregnancy and on psychostimulants for ADHD, et cetera, et cetera. If there was a new groundbreaking study that told us something new, I would be all ears, but it seems like we're in this reverse uh, position of there's a belief, and now we're trying to go hunt for data versus sort of operating off of first principles.
Yeah, it starts with a narrative. I mean, using stimulants and ADHD is a good example, and you and I have had some conversations just privately about this, about the fact that, as you said, I mean, there's more than 80 years of research on psychostimulant medications and ADHD demonstrating that these medications are safe and effective when prescribed appropriately
Yes.
to people who are properly and rigorously diagnosed ADHD.
100%.
There have been changes in the practice of medicine in the United States, particularly in the last few years, where these medications are being prescribed by more providers, including particularly by non-psychiatrists, to new patient populations. And you've explained to me how the by far the highest growth in prescriptions of stimulants is for adult women. who've been newly diagnosed with ADHD, and yet these they're not even nuances. They're just actually carefully studied and observed phenomenon that are happening in medicine and in research. Those all of those actually specific, accurate details get washed over, blurred, or ignored in the service of this larger narrative of kids are being poisoned.
Yes. Yeah. And I think it's scary if you're a parent right now, right? Like, we both continue to see patients and will continue to see patients. And, you know, I had a family come recently that wanted to, you know, uh, a consultation around folinic acid for their kid with on the autism spectrum. And like, I think there is a public duty to not offer folks false hope, and that we we should offer people the latest and greatest. There's sort of that dialectic of I want to make sure that I, that the rhetoric that is coming from the highest levels of our government, uh, from that bully pulpit, folks are getting accurate and good, sound guidance because it shows up at our front doors. And I think it's anything less than that's irresponsible, and I and and what I consider policy malpractice.
So you took us back to pre-pandemic and intra-pandemic. So 7, 6, 5 years ago, increasing focus on kids' mental health is a pressing public health concern. It's on parents' minds. It's on educators' minds. It's on public policymakers' minds. A number of steps were taken in federal policy that, as you said, were really bipartisan steps. We now get to 2025, January 2025, new administration comes in. What has changed for our federal policy, our national policy around children's mental health over the last 12 months?
I think probably the word that I would use to encapsulate is chaos and uncertainty, right? Those would probably be the two words that I would sort of think about that. And it's hard to sort of plan for a future state in the midst of chaos and uncertainty.
When federal rhetoric undermines evidence-based care, it's a failure of responsibility to the most vulnerable among us. But the impact of this moment extends far beyond questions about specific medications or treatments. There are three interconnected crises unfolding right now that together represent what Sunny calls a triple threat to children's behavioral health systems. Let's hear him break that down.
On one hand, it's sort of the rhetoric change, right? And I think that affects folks' comfort. And so we know this with the black box warning on SSRIs, right? When that for adolescents, which showed that there was based on a set of small studies that showed that there was increased suicidal ideation in adolescents that were prescribed SSRIs in a relative sense, while the absolute difference was, not so great. But it led to massive changes and shifts in prescribing practices, right? Because once that's there, it draws pause, right? And so that I think that sort of that preceded this administration, but I think there's sort of laying of groundwork that's concerning around the questions that are being raised that potentially increase distrust in behavioral health care and in the care that folks have available to them based on the rhetoric that they're hearing. So that's one. I think that the second piece that I'm sort of thinking about is the whipsaw effect around funding. And so, this grant's canceled, it's not canceled. This contract's there, it's not there. Like, How do folks in civil society who are delivering services in communities, boots on the ground, doing work across the public health continuum, upstream from mental health promotion and substance use prevention through treatment and recovery, that entire sort of arc, how do you meaningfully do your work if there's a looming threat of this funding could get canceled at any moment, right? Largely without cause, right? Or at worst, false pretense. I think the third, which is a future state that's about to happen, is massive changes from HR1 last year in 25, the One Big Beautiful Bill, that's going to have a huge impact on, $1 trillion cut in Medicaid will affect children, uh, particularly children with behavioral health issues. We know Medicaid is the biggest payer for behavioral health services in America. We know a majority of children in America are covered by Medicaid and CHIP. And we know that children, a huge percentage of children's behavioral health services are paid for uh, uh, by uh, uh, by Medicaid and CHIP. And in fact, I think there was a recent uh, I th- I want to say it was a JAMA Pediatrics paper that we had been emailing about that showed I think 40% of pediatric spend is on pediatric behavioral health. Huge, right? And so what will happen, right? I think, you know, where people are going to lose coverage is in the administrative churn, you know, because largely people that are eligible, you know, people that should get the services meet eligibility requirements. It's the additional administrative burden that we're going to pose on people. Um, uh, And I think that's going to be a huge challenge. And we solved that during the pandemic in some ways because we allowed for continuous eligibility. Because if you're a child and you're 5, you should be eligible when you're 6, and when you're 7, and when you're 8, and when you're 9. Like, it doesn't make any sense, right? It's not logical. Um, uh, and so those few things I think are going to have huge ripple effects, and we're starting to feel them now, a year from last January, and we're going to feel them for years on out.
So I just want to sort of reflect back to you a few of the things that you pointed out. So you're saying first that when powerful national leaders plant seeds of doubt in the public mind about well-researched, well-established clinical practices, that starts to influence clinical care that kids get now. So when people are starting to plan, when leaders are planning ideas that are ill-formed, not backed by research, and are sort of narrative first, we'll worry about the facts later. What happens is doctors get skittish and hesitate to prescribe treatments that can be life-saving or at least significantly life-improving for many, many children and families. And similarly, families come in doubting their care, having questions that are not informed by good science. And families want what's best for their kids. But when there is this sort of environment of confusion, doubt, and misinformation that goes on, kids' care gets affected. So that's sort of first category. Second category is for sort of players in our health system. So imagine a community health center in Illinois or in Arizona that provides care for thousands of families. And let's say a significant portion of the funding that keeps their clinic doors open comes from federal grants.
Yes.
They're part of research programs, they're part of service programs, they're part of training programs for new medical students and residents. When that funding is cut or cut and restored, the ability for that clinic to function effectively and to take care of patients and to train the next generation of doctors and to be a part of national research studies or data collection efforts, suddenly they don't know what's up and what's down. It becomes very hard for them to function as an organization.
Totally. I mean, I want to double tap on that last point that you raised, which is another facet of what's getting dismantled in ways that are not so obvious is the caps on public service loan forgiveness and the loans that folks are able to take out in healthcare professions, and which profession types are allowed to qualify. And we know many of these training programs are expensive. And me and you well know, and folks listening to this podcast may well know, the workforce challenges are central to addressing youth and family behavioral health challenges, right? Like, we're not going to get ourselves out of this without sort of grappling with how are we going to generate the workforce.
What Sunny is describing, chaos in funding, cuts to Medicaid, and disruptions to workforce pipelines, these are actually not separate problems. They're interconnected challenges that compound one another. A community health center loses a federal grant, just as Medicaid cuts are reducing their patient revenue, all while they're struggling to recruit the next generation of healthcare providers who themselves are facing new barriers to loan forgiveness. And here's something that I find particularly powerful about Sunny's analysis. He's not content to just describe these problems at the systems level. He brings it right back to what shows up in clinic, to the lived realities of children and families. He introduces a framework that I think is genuinely transformative for how we think about child and family well-being. He calls it the political determinants of health.
That we're not going to generate new folks to fill these positions out of thin air. We're going to need to support and use public resources to make a smoother glide path for people to enter the field. And I think that's a huge challenge that we're confronting right now.
Yeah, I'm glad you emphasized that point, that if we have disruptions to pipelines for training the next generation of doctors in every field, in mental health, in primary care, and a number of other fields, we are actually not going to have doctors in practice taking care of you and me, our kids, our neighbors, our parents, in a few short years. The workforces are really running thin. I want to come back to the Medicaid point too, which is, you were alluding to the fact that there's a tidal wave coming of massive plan cuts to Medicaid. And as you know, one of the things I've been most focused on is on family mental health. And so there are multi-generational factors here. There are the factors related to coverage for children's healthcare and children's behavioral healthcare in particular, and eligibility and access to Medicaid covered healthcare. As you said, more than half of kids in the country get their health insurance from Medicaid and CHIP. But then what's also certainly coming is hundreds of thousands, if not millions, of adults losing their healthcare coverage.
100%.
And many of those adults are parents and caregivers in children's lives. And so when adults lose their healthcare coverage, that also impacts children.
Yes. I mean, I sort of think about operating off of first principles, sort of Winnicott's observation that children only exist in the context of their parents or caregivers or adults, that there is this dyadic relationship, right? And this ecosystem within the family, which then sort of, extends out, but children don't exist in isolation. And so if we want to think about how do we support children, how do we support those who support children, right? It's not going to be enough and I think that's where that's the additional sort of Medicaid burden that's coming down the pipe, right? Which is an expanded workforce requirement, which obviously affects adults, but we know that those that requirement doesn't actually change. Uh, 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 it's actually increasingly burdensome to administer, and and experience in states like Arkansas that have implemented it demonstrate the juice is not worth the squeeze.
Say more about that.
Like, the administrative burden it takes to verify and keep track of all of that, and the attendant costs of disenrollment and all of that, it's not a good policy solution. I understand where it comes from. Uh, and I think that's where we can have a nuanced conversation on how we sort of address maximal employment in our society. It's not necessarily my area of expertise. That's probably as much as I could say about that. But uh, but but there could be a conversation to have there. But is that the right solution to solve that? Because, well, okay, we want to do that, and on the other hand, uh, there's massive cuts to federal child care grants for poor people. And so how are you going to work if the child care you rely on to work is now pulled out of 5 states, right? Based on, frankly, xenophobia, right? Around concern around my immigrants abusing childcare, which, it's sort of hard. It appears to be a form of collective punishment to poor people, and like that's antithetical to what we would think about are the social conditions required for thriving families.
Right. Right. I think you're alluding to the fact that there have been these actions on the part of the federal administration to single out states as undeserving of a range of services and supports that have been federally funded as a result of perceived immigration policies or stances, right?
100%. And like for me, it's babies don't pick the zip code that they're born in. They don't pick if they are born in a blue state. And I think to me that's like it's baffling to me of like, why are we punishing babies? Like, and really like should have that conversation,
So your mind, I'm going to take it in a different direction here because we want to get to, as you know, extraordinary solutions for these times, right? And so I would love your perspective as somebody who was a public servant prior to coming to Georgetown.
And I really think we need a broader frame around the political determinants of health, right? And I would distinguish the political from partisan, right? That like it doesn't have to be filled with partisan strife, but to recognize political that there are what you're describing are decisions that a society takes collectively, a politics of sorts, right? And for children and their families, there are these political determinants of health that we see at the front doors of our clinics, right? Like, and 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 as physicians, we have a particular perspective when these problems from the general society come to my doorstep. When a 5-year-old is starting to wet her bed again because she's seeing armed ICE patrols outside of her childcare center. When a transgender, child is, afraid of going to school because of, uh, you know, uh, uh, being able to use the restroom of their choice, right? When like this can continue onward, but could I treat these with medication? Sort of, kind of, but they actually extend beyond the four walls of our clinic or hospitals or other settings of formal care. And recognizing that these are choices that we are making as a society in how, not necessarily consciously every day, but like there is a place of civic participation for us to be civic participants and to make a decision consciously that we're going to support children's well-being.
This concept of political determinants of health, the idea that collective societal decisions profoundly shape children's well-being, raise a fundamental question. Why don't we as a society invest more in children and families? The return on investment is clear. The evidence is overwhelming. The moral case is unassailable. And yet year after year, decade after decade, we make different choices. Sunny has thought deeply about this question, both from his experience in government, as well as from his perspective as a clinician and as a parent. His answer gets at something fundamental about power, agency, and voice in American democracy.
What are the choices that we make as a society about investing in children so far? Like, what's the story of that? What's the American story about how we see our public investment with regard to investment in kids as opposed to investment in other segments of our society?
Yeah, I mean, I think one of the realities that we're confronted with are children as political actors lack full agency within our society. And I know a lot of our conversation has sort of floated to the airy and the philosophical, but I think it's important to sort of recognize, yeah, there are activist movements that children are leading and young people are leading, and we really should be following, and there's sort of moral clarity there. And one of the things a young person said to me a couple of years ago is like, I don't know the intricacies of how the government works, but I know what doesn't work and I know what I need. And like, you need to help me figure out the policy solutions. And I thought that was so profound of like, yeah, you can't know how a budget process works. You don't need to know that today, but you do know that it's really hard to see your school-based therapist, and that how do we solve that for you if you need to talk to somebody? Like, that's a tangible problem. We need to digest it and figure out how do we sort of find a solution. So I think the lack of sort of and yes, there are tons of child-focused advocacy groups and professional medical societies and
but what about actual dollars?
Yeah, I think the dollars. Say more around the actual dollars.
I guess that my observation, somebody who's never worked in government, is that we spend most of our dollars on older people. We spend most of our healthcare dollars on the end of life. We spend most of our public benefits dollars on Social Security and people in the last stages of life, which is, it just seems to me like a decision that we've made, that the overwhelming investment that we make is in the last stages of life. And despite the fact that there's enormous both evidence and common sense that dictates that investing in children and in young people and in families is where the greatest return on investment is likely to be. It's, can feel icky to use that ROI terminology around people's lives, but if we think about where the return comes from investing early, comes from improving trajectories across an entire lifespan. And yet we have never made that choice as a nation. Like the percentages of dollars spent, I know healthcare best, on end of life care dwarf the dollars that we spend, for example, on preventive medicine. Why do we do that? And is that something that we should think about changing?
Yeah, I mean, some of it probably ties back to this piece around political agency and who are actors in our democracy. Yes. And I think the second piece is a more general comment around public health writ large, right? Like it's really hard to, and I think there's a whole science around the communication of sort of the prevention and promotion work that it's hard to sort of make that argument that a dollar saved today, a dollar invested today will yield $7 5 years from now. People are looking for, well, I think the incentives within our system are sort of uh, are backwards in some ways, right? Of uh, 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 sort of eat what you kill model, which I think will phase out in, uh, or at least CMS has sort of put that out in the next, uh, 5-10 year horizon around, value-based care being a crux of the of sort of the orientation of, public healthcare benefits. Because we need to show that quality and there's a return uh, uh, for what the cost is, right? That there is a value that we're sort of gaining out of that. I I I think that of course we should be investing more in children. And often when, the federal government can run a deficit, uh, state governments can't run a deficit. And so when they need to balance the budget, what gets cut? Often children's services, because that's uh, you gotta there's it's arithmetic or accounting or whatever, like you have to get to a balanced budget, and there's only so many things you can cut. And yeah, I don't know if we need to put ourselves in this bind of, you know, um, of value decisions on sort of what segment of the population, but it's really like, how do we, if we have rhetoric that says we care about children, like we just need to back that up in ways that are tangible and material and that help families thrive, right? And I think that's sorely lacking.
I don't want to be zero-sum about it, but
Yeah.
but we don't have infinite resources.
Yeah.
And I would like to live in a society that says, in good years and bad, when the coffers are full, when the coffers are strained, we dedicate a quarter of our resources as a public to young people, for example. I'm making up a number, but that because you can't spend infinitely and everywhere, and there are choices to make. But I agree with you that reliably and regularly the choice that's made is to squeeze education, to squeeze healthcare for children, to squeeze the kind of community resources that are good for families, to squeeze childcare. Like those are the choices that get made again and again and again in favor of leaving other resources untouched. And that seems to me increasingly unjustifiable.
Well, I think in this moment,
it's not the choices that other societies make.
Totally. I mean, and I think right now in this current moment, and I know so much of what we've talked about has edged around the political, and I'm happy to address that head on too. But it's this current moment we find ourselves sort of the word du jour is around affordability, and childcare is at the top of that agenda.
That young person's voice saying, I don't know the intricacies of how government works, but I know what doesn't work and I know what I need. That really stays with me throughout this conversation. It cuts right to the heart of what we're talking about on this podcast. What do children and families need to thrive? And what are we as adults, as systems, as a society, willing to do about it? I asked Sunny to help me understand where we go from here. Times of crisis can be times of opportunity. Opportunities to rethink, reimagine, redesign, rebuild. So what are those opportunities now? What are the extraordinary solutions that might emerge from these extraordinary times?
This is it's a vastly overused phrase, but times of crisis or times of opportunity, right? Mm-hmm. So if you put on your most creative lenses, what are the opportunities here to reshape the landscape of what mental health care looks like for kids and families going forward?
Right. So, I mean, I think the biggest picture in terms of sort of how federal resources are organized, what's effectively happening at this moment is a hollowing out of the civil service, as we've talked about, and massive shifts in dollars that are getting dispersed to the organizations to support the American public. So in this moment, we have a opportunity to sort of rethink how we organize our work that supports children's behavioral health and family well-being, right? And I think what ends up happening is sort of this accretion pattern of, you know, uh, uh, year after year, sort of like sedimentary rock. There's a new layer that's sort of added, and sometimes it's added in the right place, and sometimes it's added in another place. Sometimes it looks like duplicative in where work is, and and so we have an opportunity to take stock of like not necessarily wedded to a particular program, but to the function of programs that support children and families, and what should that look like? And I think the current way that sort of it's been played out, and this is sort of an antidote to what's happened, right? Which is let's cut first, figure it out later. And it's like, well, actually, like, what should that path forward look like? And then how do we, advocate for how that's organized, right? And if you looked at the federal government, children's behavioral health sits in lots of different places within the federal government, right? And you could make that same argument. Maternal health sits in lots of different parts of the federal government. And so, there's this perennial question around lumping and splitting of like, how do we bring things together? Should they be apart? But I think that's where a critical opportunity lies for us, right? Is in rethinking the structure and sort of the structure then helps give us an idea around function, right? And so I think on the ground, a lot of the work that you're doing around family mental health is a frame shift in how we're sort of thinking. And so I think that offers a tangible opportunity, right? Of well, children don't exist in isolation. They only exist in the context of caregiver. That's a first principle. Well, how do we wholly support, that unit that then we're able to organize around, right? And that uh, is a change from the paradigm that we've operated from. And so, I sort of think about uh, Kuhn and the nature of scientific revolutions, right? That they require paradigmatic shifts and the old science doesn't apply, and we have sort of new science to explain and understand. And I think we're in some version of a potential analogous version of what's possible in paradigm shifts in how we think about policy as written and sort of how do we draw down from sort of reorganizing at the top and sort of how do we help support that on the ground?
Yeah, so let's carry that forward. So there are some paradigm shifts that could take place within healthcare, right? Including families and mental health care is an example. And mental health is fundamentally a social phenomenon. We all exist in relationships. Kids' mental health affects their parents. Parents' mental health affects their kids. We need to sort of create some union here in how we think about this. That's a potential paradigm shift. There are other potential paradigm shifts within the way we provide mental health care as well. What about paradigm shifts that have to do with our mental health that are not about mental health care, but are rather about the ways, speaking about kids, the places and the ways that kids live in the real world, live online, the way that kids learn, the way that schools operate and function, the way that kids live outside of school.
Yes.
There's part of the mental health crisis is that more kids need more care. I think another part of the mental health crisis is how can we help more kids to be less miserable?
100%. And I think that's an excellent point, right? That we sort of need to address the social ecology that children exist in. And so families are one part of that social ecology. And one of the things I worked on when I was in federal government was around kids' online health and safety and working on an interagency task force that sort of brought a whole of government approach to how do we help protect kids online, right? And I think, there's sort of been stalled legislation around kids' online safety,
It sure
right?
has.
And we've seen our European partners, take a much more progressive stance,
And now
right?
Australia
And
too.
Australia with the ban. And I think, me and you have had many conversations about this, previously, but I sort of think of these as sort of naturalistic social experiments, right? And so, like, we don't often have the ability to run policy experiments, and I think experiments sort of has connotations that we're sort of guinea pigging out population, but we're comparing, right? Like, okay, so Utah has age verification sort of policy, and Australia has this total ban. Like, how does that play out? What are the outcomes? We should follow this, right? Like, we should be rigorous and scientific, and science as a means of sort of uncovering the truth. We should just know, like, does this work? Is this effective? Because there have been previous versions on, so like for, pulling that thread on online safety with COPPA, right? The Kids Online and Protection, Privacy Protection Act, where, there's a button that, of are you 18 or are you 13 or, to enter. And then the kid presses it. And then they enter this world. And so, like, was that a policy solution? Was that part of that policy solution working as intended? Right? I don't know, right? And so I sort of wish to apply the same rigor to all of these sorts of solutions. We should be creative about them, right? And sort of think about how do we protect kids online? Like, how do we make schools a place where children thrive, right? And it's not just a place for them to show up, right? And we know the graduation rates are abysmal, and we know kids are falling behind in learning, and we know a lot of that, as sort of attended consequences after the pandemic. But I would not use the pandemic as the only sort of risk factor there, right? That's like these were trends that also preceded.
Yes, they were.
I sort of think about acute on chronic problems. I also think about the youth mental health crisis as an acute on chronic crisis, right? Like, people talk about bedboarding as like this just happened where kids spend a long time in the emergency department trying to get a hospital placement. It's like it's been a perennial issue. It's acute now, but we should sort of appreciate that. But yeah, it's what, and then what are the ways that we can do upstream promotion, mental health promotion and prevention work of like, how do we support sort of physical activity and so, allow children to sort of experience play and ways to generate well-being. Like we sort of need to expand the aperture and invest resources to do that. And I think that's one of the places where so much of the funding that was cut on January 13th uh, uh, was on mental health promotion and prevention programs. And you're like, wait, uh, these are programs that don't often have clear ways to bill insurance, but they're still needed as population sort of intervention.
Well, there's another potential paradigm shift is the moving away from the requirement that in order to intervene to support children's mental health, that there needs to be a psychiatric diagnosis.
Totally. And that was one of the things that we had done with EPSDT guidance that was put out, during the last administration, was in clarifying that that's not a federal requirement.
Right.
And that and in this letter to state health officials, like, say, yes, that is something that in the way that you can go to the pediatrician and and your kid has a fever, and then they can get evaluated for fever. They don't necessarily we don't need to know which virus
That's right.
is causing the fever.
That's right.
Right. We can do, many states have been sort of working on routine well visits and preventive visits. And I think those are also policy experiments, right? What's the uptake? What does that look like? Are people using it? is this working as intended? How do we tweak it? Like, how do we make this better? And I sort of, I'm an incrementalist. While I feel I'm a radical, have radical feelings, but like, I'm pragmatic. Like, we should build upon uh sort of the steps that we've sort of been sort of bricks that we've been laying, instead of sort of tearing totally down and having to start tabula rasa, right? Like, I think it's ahistorical, and and it's easy to break something, and it's really hard to build and transform something.
So with that caution in mind, I want to ask you about hope. What are you most hopeful about building and maintaining and sort of leading toward in kids' behavioral health right now, even in the current context? Where do you find sources of hope?
At the risk of being tried, I mean, the place that I find hope is with young people and in talking to them, because we are sort of temporary custodians of the world that they will inherit, right? And that they are inheriting. And I think they're coming up with all sorts of interesting solutions, right? Like, they know that they're engaged in peer support, and, sort of expanding the reaches of what care looks like, right? And they're asking us for what they need and want, and the sort of I don't know if I noticed this as a when I was a young person. It was a bit ago, but they are sophisticated and thoughtful and loud and present, and in the mental health space, like, they're there and they're asking us for the kinds of care that they need. So I think for a true north, I sort of look there for inspiration, for hope, because sometimes I look around and I'm not feeling as inspired. I think in terms of where are we heading? I think we have a fragmented system of care delivery, particularly for kiddos. And so what a true north would be is really thinking about upstream intervention, finding ways to help blend funding, do that sort of wonky work in how do we make these programs sustainable? Because every grant has a line in it, which is a requirement of one must show financial sustainability. And like, okay, but you're not actually setting me up for that, dude. So like, how are we making that explicit and doing that work in tests of change of, well, what does it look like to use the full weight of EPSDT, which is a unique guaranteed benefit around early periodic screening, diagnosis, and treatment for kids under 21. Like, how are we using the full weight of that in support of children's behavioral health?
I love your answer, because it's you're bringing together the sort of the eternal hope that comes from really listening to young people with your the draw that you feel back into the weeds of policy, and how do you actually do the wonky stuff to make things work. So
we need to make the playbooks, and we need to do the tests of change. We need to support states as they're sort of finding their path through this, and then do the work in communities and show up. So much of this is showing up and being in solidarity of like, these are hard times and we're going to do it together.
Perfect place to stop. Dr. Sunny Patel, thanks so much for joining me today.
Yeah, thanks so much for having me. Yeah, this is great.
I want to close with something that Sunny said that really encapsulates the spirit of this conversation and the mission of the podcast. He said, so much of this is showing up and being in solidarity of like, these are hard times and we're going to do it together. Showing up, being in solidarity, doing it together. That's what thriving looks like in hard times. That's what extraordinary solutions require. The challenges Sunny describes are real and urgent. The changes in funding, Medicaid cuts, workforce pipelines under threat. children and families caught in the middle of policy whiplash. But what also comes through clearly in its conversation is that there are pathways forward. There are opportunities to reorganize how federal work supporting children is structured. There can be paradigm shifts in how we think about family mental health and the political determinants of health. Policy experiments in states and communities that we can learn from. And most importantly, young people themselves, who are sophisticated, thoughtful, loud, and proud. They can show us what they need. As Sunny reminds us, we're all temporary custodians of the world that young people are inheriting. The question before us is, how will we show up for them in this moment? That's our show for this week. I'm Matt Biel. You can learn more about our work at the Thrive Center at thrivecenter.georgetown.edu. We also have a newsletter where you can read interview highlights from this conversation and get updates about what our Thrive community is thinking about and working on. You can subscribe to our newsletter at the website as well. Thanks so much, and until next time.